Hello and welcome back to the PMHNP podcast. This is Dr. John Rossi with Clarity Education Systems and www.pmhnptesting.com. So excited to be here with you today. We're going to dive into ADHD, or attention deficit hyperactivity disorder, and we're really going to explore how we diagnose this according to the DSM-5, the specific characteristics of this disorder, the types of the disorder, and what we do pharmacologically and non-pharmacologically for treatment of both adolescents, young adults, and adults alike. So looking forward to diving into this a little bit more, and go ahead and grab your notebooks, grab your study materials, and we'll go ahead and get started on this topic of ADHD treatment and diagnosing. Now, the DSM-5 outlines specific diagnostic criteria for ADHD. Remember, this is a neurodevelopmental disorder that is characterized by persistent patterns of inattention and or hyperactivity, impulsivity that are inconsistent with an individual's developmental level and impairs functioning. So these symptoms must be present in two or more settings, like at home, school, or at work, and they must cause some significant impairment. So let's break down step by step, focusing on what you need to know for the certification review. First, DSM-5 identifies those two core symptom domains, inattention and hyperactivity impulsivity. Now, a diagnosis of ADHD requires meeting criteria for one or both depending on the presentation. And this is how it works. So for inattention, this is for anyone under the age of 18. At least 6 of symptoms must be present for at least a 6-month period of time to a degree that it's inappropriate for their developmental level. And then for individuals 18 and older, only 5 symptoms are required. And so we're looking at symptoms like failing to pay close attention to details or makes careless mistakes at work, at school, or in other activities, often has difficulty sustaining attention in tasks or play, often does not seem to listen when spoken to directly, does not follow through on instructions, and fails to finish tasks, often has difficulties organizing tasks and activities, will avoid or is reluctant to engage in tasks that require sustained mental effort. We often lose things that are necessary for tasks like school materials or their keys or wallet, and often are easily distracted by extraneous stimuli. So it's often noticeable that they forget their daily activities. So I want you to picture a student who misplaces their homework or zones out during lectures or struggles to prioritize assessments. Those are the classic signs of inattention. Now, for hyperactivity and impulsivity, again, 6 symptoms for kids, 5 or more for adults. These are going to include often fidgeting with or taps their feet or their hands or squirms a lot in their seats. They'll often leave their seat in situations when remaining seated is expected. They'll run or climb in inappropriate situations. For adolescents or adults, this may just manifest as restlessness. Now, they're often unable to play or engage in activities quietly. It's often seen as on the go or acting as if they are driven by a motor. They will oftentimes talk excessively. They'll blurt out answers before a question is completed. And they have a general lack of difficulty, or they have this difficulty in waiting their turn, right? So they often interrupt or intrude on others. This is what we see as like butting in on a conversation or butting in when they're playing a game. So I want you to think of a child who can't, sit still or stay seated in class, or an adult who impulsively interrupts colleagues. These behaviors are going to disrupt functioning across multiple settings. Now, ADHD is classified into 3 presentations, right? These are based on the predominant symptoms. We have predominantly inattentive presentation that's going to meet the criteria for inattention, but not hyperactivity, impulsivity. We have predominantly hyperactive impulsive presentation. Again, that's going to meet criteria for hyperactive, impulsive, and not inattention. And then we do have a combined presentation. So there we're going to see this criteria for both inattention and hyperactivity, impulsivity. Now, these presentations, they can shift over time. So as PMHNPs, you'll need to reassess patients periodically. Now, for the exam, I want you to remember the combined presentation is the most common in children, while adults, they often present with predominantly inattentive symptoms. Now, let's go beyond just the symptoms and let's talk about what the DSM-5 has added for additional requirements here. So first is going to be the age of onset. So several symptoms must be present before the age of 12. This is critical. Remember, ADHD is a neurodevelopmental disorder, so symptoms don't just suddenly appear in adulthood without some childhood history. Then we have the multiple settings requirement, so symptoms must occur in 2 or more settings, like at home, at school, or we could even say it's the daycare environment. And that is needed in order to rule out any type of situational factors that may actually be influencing the way the person is behaving, and it isn't actually attributed to a disorder like ADHD. Third is going to be functional impairment. So symptoms must interfere with social, academic, or occupational functioning. Now, there is the exclusion of other disorders that must be taken into account. So symptoms that should be better explained by another mental health condition like anxiety or some type of mood disorder or substance use cannot be, pinpointed on ADHD. We have to look at the other symptoms and disorders that actually exist as well. Now, for your exam, expect questions that test your ability to differentiate ADHD from these lookalikes like anxiety or other types of learning disorders based on the criteria that they present. So you'll also need to know how to apply the symptom thresholds during those different ages, right, that we talked about. 12, being a young person as opposed to an adult. So really, that's the DSM-5 criteria for ADHD. It's a nutshell review here. So you want to keep that in your mental toolbox. 6 symptoms for kids, 5 symptoms for adults, 2 domains or 2 locations, 3 presentations, and those extra requirements like age of onset and impairment. So next, we're going to tackle the differential diagnoses that are really going to help you sharpen your clinical reasoning and help you make the right diagnosis depending on the symptoms and the history of the patient. So remember and recall that ADHD's core symptoms, those inattention, hyperactive, and impulsivity situations, aren't unique to ADHD, right? Many psychiatric, many medical, and environmental conditions, they can present similarly. As future PMHNPs or current PMHNPs, you'll need to tease these apart. So for your certification exam, I want you to expect to find case-based questions that really challenge you to rule out other disorders based on history, the presentation of the patient, and those DSM-5 criteria. So let's walk through the key differential diagnoses for ADHD, focusing on what sets them apart. First, we have anxiety disorders. So anxiety can look a lot like ADHD, especially the inattentive presentation. A child or adult with generalized anxiety disorder or social anxiety may appear distracted, forgetful, or fidgety due to the excessive worry or hypervigilance. Now, unlike ADHD, anxiety-driven inattention is often tied to a specific trigger, like social situations or some type of performance stressor. So the key differential here is ADHD symptoms are pervasive across settings, while anxiety, these can fluctuate based on the stressor. So ask about worry, about fears, or physical symptoms like a racing heart in order to rule out anxiety. Next, we have mood disorders. So bipolar disorder and major depressive disorder, these can mimic ADHD as well. Now, in bipolar disorder, especially in children, the irritability, impulsivity, and high energy during a manic or hypomanic episode, this can really resemble, an ADHD hyperactivity, impulsivity situation. Whereas depression, on the other hand, this is where we can cause poor concentration, we see low motivation, they start mimicking inattention. And the key here is timing, okay? So ADHD symptoms are chronic and present before the age of 12, while mood disorders, these often have episodic symptoms or later onset, right? So I want you to look for mood-specific signs like euphoria or suicidal ideation in order to guide that diagnosis. Third, we need to talk about learning disorders. So specific learning disorders like dyslexia or dyscalculia, these can cause academic struggles that look like ADHD's inattention. Now, a student who can't focus on reading or math may seem distractible, but the issue is task-specific and it's not pervasive. Unlike ADHD, learning disorders don't typically involve hyperactivity or impulsivity. So use the academic history of the patient and any psychoeducational testing in order to differentiate. ADHD affects multiple domains, not just one subject. Number 4 is going to be oppositional defiant disorder, or what's known as ODD. Now, ODD is common in children. It involves defiance and argumentiveness, and that can overlap with ADHD's impulsivity or emotional dysregulation. But ODD behaviors are typically directed at authority figures and stem from this emotional reactivity, not a neurodevelopmental deficit. ADHD kids may act impulsively across contexts, while ODD, their behaviors are more situational. So we want to check for a pattern of hostility or vindictiveness in order to lean towards that ODD diagnosis. Number 5 is autism spectrum disorder, or ASD. Now, ASD, this can present with social deficits, repetitive behaviors, and trouble focusing, which may definitely be mistaken for ADHD. Both conditions can involve this impulsivity or inattention, but ASD includes core deficits in social communication and restricted interests. So, for example, an ADHD child might interrupt due to impulsivity, while an ASD child might actually struggle with the conversation and reciprocity. Okay, so developmental history and social interaction patterns, these are going to be key in distinguishing between the autism and ADHD situations. Next up, we have medical conditions. So we can't overlook some of the physical health issues. So conditions like a thyroid disorder or sleep apnea or, lead exposure, these can all cause inattention or hyperactivity. So for instance, hypothyroidism can lead to sluggishness and poor focus, while sleep apnea leads to daytime fatigue that mimics inattention. So seizure disorders like absence seizures, these can also look like what we know as zoning out. So always ask about the medical history, their sleep patterns, and their neurological symptoms. So lab tests or referrals to another specialist may be needed in order to rule out these other medical conditions. Number 7 is going to be substance use or medication effects. So in adolescents and adults, substance use like cannabis, alcohol, or stimulants, these can all impair attention and they can all cause agitation, which mimics ADHD. Also, medications like antihistamines or corticosteroids, these can affect focus or behavior. So unlike ADHD, these effects are tied to substance use or medication timing, not this lifelong pattern that we see. A thorough substance and medication history is critical, especially for adult patients. Now, finally, we need to consider the environmental factors, so things like trauma, neglect, or a chaotic home environment. These can all lead to behaviors that resemble ADHD, especially in children. So chronic stress may cause hypervigilance or this difficulty in concentrating. But these are often context specific, and they really lack an early onset of ADHD. So we want to use trauma-informed screening tools and then gather a detailed psychosocial history in order to differentiate. Now for the exam, this is your pro tip here, right? Focus on onset, the context, and co-occurring symptoms. ADHD starts before the age of 12, is consistent across settings, and isn't better explained by any other condition or medical issue. So a good history to see the collateral from parents, the teachers, or their partners is going to be your best tool. Also, I want you to watch for comorbidities such as ADHD often coexisting with anxiety, depression, or learning disorders. And that's going to really complicate the picture that we're seeing. All right, so that's the quick breakdown and rundown on differential diagnoses. So we want to keep these in mind, right? Anxiety, mood disorders, learning disorders, ODD, autism, medical conditions, and substance use. And we also need to consider the environmental factors. So practice ruling them out with case studies, and you'll be able to ace those type of questions on the exam. So next up, we want to explore evidence-based treatments for ADHD to round out this certification prep review specific to attention deficit hyperactivity. So let's jump on to that next section here, and we'll go over the neurodevelopmental disorder that is rooted in complex interactions between genetics, brain structures, and neurochemistry first, all right? So before we can actually talk about these pharmacological and non-pharmacological treatments, we have to understand the biology and the history behind ADHD in order to justify those treatment choices. All right, so let's break down 3 key areas. First, we're going to talk about neurotransmitters, then we're going to go over brain structures, and then associated abnormalities. All right, first the neurotransmitters, and this is the chemical messenger, right? So ADHD is strongly linked to dysregulation of 2 key neurotransmitters, specifically dopamine and norepinephrine. Now, these chemicals, they regulate attention, motivation, and impulse control, and in ADHD, their signaling is disrupted. So we see dopamine, this neurotransmitter is going to be critical for reward processing, for motivation, and for sustaining attention. In ADHD, there is evidence of reduced dopamine activity in certain brain regions, and that's what's going to lead to these difficulties of focusing on tasks that are assigned, and when they're not immediately rewarding, they're going to have a hard time focusing on it. So think of a patient who can play video games for hours, but struggles with homework. Low dopamine signaling makes mundane tasks feel unrewarding. Then we have norepinephrine. So this neurotransmitter modulates arousal, alertness, and executive functioning, like planning and impulse control. So in ADHD, norepinephrine imbalances, these are really going to contribute to distractibility and impulsive behaviors. It's why patients might act without thinking, or they struggle to stay on task. So the catecholamine hypothesis ties these together, suggesting that ADHD results from impaired dopamine and norepinephrine transmission in neural circuits. So medications like methylphenidate and amphetamines, these are going to work by increasing the availability of these neurotransmitters in the synapses, and that's what's going to help improve attention and impulse control. So for the exam, know that dopamine and norepinephrine are the stars of the ADHD neurochemical show. Number 2 is brain structures. So let's talk about the neural activity and neural architecture. So ADHD is associated with differences in brain regions, several brain regions that are involved in attention, executive functioning, and motor control. So neuroimaging studies like an MRI and also fMRIs, these show the structural and functional abnormalities in these following areas that we're going to review. First is going to be the prefrontal cortex, or PFC. Now, the PFC, especially the dorsolateral prefrontal cortex, this is crucial for executive functioning like planning, working, memory, and impulse control. In ADHD, the PFC is often underactive or smaller in volume, and that's what's going to lead to difficulties organizing tasks or inhibiting impulsive actions. This is why a patient might blurt out answers or struggle to prioritize. Next is the anterior cingulate cortex, or the ACC. Now, the ACC helps with error detection, emotional regulation, and attention allocation. So in ADHD, a reduced ACC activity is going to contribute to these problems, shifting focus or regulating emotions, explaining why patients might get stuck on a task or where they might overreact to frustration. Next is the basal ganglia. So this is a group of structures, including the striatum, that regulate motor activity and reward processing. So in ADHD, the basal ganglia show a reduced volume and altered dopamine signaling, and this contributes to hyperactivity and impulsivity. So think of a child who fidgets constantly. This could tie back to a basal ganglia dysfunction. Then we have the cerebellum. So traditionally, this is linked to motor coordination. The cerebellum also plays a role in cognitive timing and attention. So in ADHD, cerebellar abnormalities, particularly in the vermis, these are associated with difficulties in timing tasks or sustaining attention, which can manifest as poor time management. And then we have the corpus callosum. So this is the structure that connects the brain's hemispheres, and this facilitates communication between the hemispheres. So in ADHD, a smaller or less efficient corpus callosum may impair integration of cognitive and emotional processes, and that's what's going to contribute to disorganized behavior. So for the exam, I want you to remember the frontal striatal cerebellar circuit, and that's a tongue twister, is it even as I say it. So the frontal striatal cerebellar circuit, this is a key player in ADHD. So dysfunction in this network is going to disrupt the brain's ability to regulate attention, behavior, and emotion. So number three, we're going to look at abnormalities and contributing factors, okay? So beyond neurotransmitters and structures, ADHD is associated with several abnormalities and risk factors that shape the neurobiology. First are genetic factors. So ADHD has a highly heritable rate. It's estimated somewhere between 70 and 80%. So genes involved in dopamine regulation, like the DRD2 or dopamine D2 receptor, and the DAT1 or the dopamine transporter, these genes are usually implicated. So these genetic variations affect how dopamine is processed, and that's going to contribute to ADHD symptoms. So for your exam, you need to know that ADHD often runs in families, and there is a strong family history. That is a red flag for the actual disorder. Next is structural and functional abnormalities. So neuroimaging shows that individuals with ADHD often have delayed cortical maturation. Okay, so this is particularly found in that prefrontal cortex, with peak cortical thickness occurring later in the peers. So this delay aligns with symptoms improving in some individuals as they get older, right? So we see an improvement within this maturation as they grow up, as they grow older, but it is more pronounced and more difficult in their younger years. So functional studies also reveal that there is hypoactivation in attention-related networks and hyperactivation in default mode networks. That's what's explaining why patients struggle to stay focused. So white matter differences that exist, diffusion tensor imaging, this is going to reveal in many cases an altered white matter tract, okay, like a superior longitudinal fasciculus, which this is going to connect the frontal and parietal regions. So these differences impair efficient communication between the brain areas, and that's what's going to contribute to executive dysfunction. Then, we've talked about this a little bit already, we have the environmental factors. And so while genetics play a big part in this disease, in this disorder, environmental factors like prenatal exposure to toxins such as alcohol and tobacco, we see low birth rate or early psychosocial adversity. These can all increase ADHD risks in a child. So these factors may disrupt neurodevelopment, and that's what's going to amplify the genetic predispositions. Then we have neuroinflammation and oxidative stress. So emerging research, and this is really exciting stuff, this is going to suggest that low-grade inflammation or oxidative stress in the brain may also contribute to ADHD, and this is because it affects neuronal signaling. So this is still an evolving area. There's not a whole lot of evidence or research, but it highlights the complexity of the disorder itself. All right, so let's tie this together for the certification prep. ADHD stems from dysregulation of dopamine and norepinephrine with key brain regions like the prefrontal cortex, the basal ganglia, and the cerebellum, and that's going to show structural and functional differences. Then we have genetic factors, delayed cortical maturation, and environmental influences that further shape this disorder. So an example for the exam, we want to expect questions that link these mechanisms to symptoms or their treatments, like how stimulants target dopamine or how prefrontal deficits cause impulsivity. Now that's the scientific foundation that we need for ADHD. So keep those concepts in mind as we move forward. Catecholamines, the frontal striatocerebellar circuits, and genetic environmental interplay. All right, so next we're going to dive into the treatments. Now that we understand the symptoms, the diagnoses, the differentials, the science, and the foundations of biology behind ADHD, we're going to be able to put that together with appropriate FDA-approved and off-label use interventions for both medication and for non-pharmacological or therapy-related interventions for the patient. So first and foremost here, we have to talk about the importance of screening. So screening for ADHD is about identifying individuals who need a full diagnostic evaluation. That way, we rule out other causes of inattention, hyperactivity, or impulsivity. So early and accurate screening can prevent misdiagnosis. It can reduce the functional impairment for the patient, and it can improve the overall outcomes for the patient as well. So for children, this might mean better academic performance, it might mean better social skills, and then for your adults, it could mean improved work productivity and improved relationships. Now, the DSM-5 requires symptoms to be present, remember, in 2 or more settings and cause significant impairment. That's going to make screening a collaborative effort. So without proper screening, you risk missing ADHD or mistaking it for anxiety, a learning disorder, or some type of behavioral issue. So for the certification exam, you want to expect questions that test your ability to select appropriate screening tools and then how to interpret those findings from multiple sources. So screening isn't just about checking boxes, okay? It's about setting the stage for holistic care. Number 2 is really about best screening tools, all right? There's no single test for ADHD, so screening relies on standardized, validated tools that gather information about symptoms, the severity of the symptoms, and then how these symptoms have impaired the patient in some way. So these tools are typically rating scales or questionnaires that are completed by patients, by the parents, teachers, or other caregivers. And in some cases, we may look at job performance and have they been written up? Have they gotten in trouble on the job? Things like that. So let's go over the best tools in order for you to understand the exam processes and practices. So first, we have the Vanderbilt ADHD Diagnostic Rating Scale, or the VADRS. So this is honestly the go-to for children aged 6 to 12. It's going to include parent and teacher versions. It's going to assess DSM-5 criteria for inattention, hyperactivity, impulsivity, and then common comorbidities like oppositional defiant disorder and anxiety. So the Vanderbilt, it's free, it's easy to score, and it's widely used in primary care and in mental health settings. So we start to bridge that gap between those two practices. So it's a favorite for exam questions because it really covers multiple domains and settings. So make sure you understand the Vanderbilt. Then we have the Conners rating scale, or what's known as the Conners 4. This was recently updated. So the Conners 4 is a comprehensive tool, and we use this for ages 6 to 18 with parent, teacher, and self-report versions available. So this is going to evaluate ADHD symptoms. It's going to look at executive functioning. It's going to look at emotional lability, and it includes this kind of short form for quick screening, okay? So its strength is its sensitivity to specific severity and impairment. And that's what makes it ideal for tracking treatment response. So this one, the Conners rating scale, is really known for its versatility and its psychometric rigor, something that we can use over time. Then we do have the ADHD rating scale 5. So this scale aligns directly with DSM-5 criteria, and it's used for children and adolescents, typically between the age of 5 and 17. It has a parent, and it also has a teacher version, and it's focusing on frequent and severity of those 18 DSM-5 symptoms. So why is it a good option? Because it's quick, it's reliable, and it's great for initial screening and that monitoring process. So for the exam, note its specificity to ADHD symptoms for that ADHD rating scale -5. Then we have the Adult ADHD Self-Report Scale, ASRS version 1.1. This is for adults, obviously. The ASRS is the gold standard. Now, it was developed by the World Health Organization. It's a 6-item screening tool. So Part A identifies adults needing further evaluation with an optional 18-item question checklist. And then we have Part B. This is for symptom details. So it's free, it's quick, it's sensitive to adult-specific presentations. For example, disorganization and restlessness in the workforce and at home. And so you'll expect this on your exam when they're talking about an adult case of ADHD. And then finally, and there's others, but let's talk about the Behavior Assessment System for Children, or the BASC-3. So this is a broader ADHD-specific tool. The BASC-3 assesses behavior, it assesses emotions and adaptive skills in children and adolescents. So parent, teacher, and self-report forms are going to make it useful for identifying the ADHD alongside any type of comorbidities like anxiety or depression. It's less specific, but great for differential diagnoses. All right, so for the exam, focus on the Vanderbilt and the Conners for kids and the ASRS for adults. So these tools are evidence-based, they align with the DSM-5, and are practical for clinical settings. We can use it in primary care. We can use them in mental health care. So always combine them with a thorough clinical interview to confirm any findings that you think are happening. As no tool is diagnostic on its own. You play the biggest part of that. So here we're going to talk about the critical role of parents and teachers. So parents and teachers, they really are your eyes and ears in the diagnostic process. So since ADHD symptoms must be present in multiple settings, their observations are essential for meeting those DSM-5 criteria and then ruling out any other situational factors that may be present. So here's why they matter, and here's how we as PMHNPs can leverage their input. So for parents, parents provide insight into that child's behavior at home during routines and in social settings, right? They can report on early developmental history, look at symptom onset. Again, that's critical, right, for that DSM-5 age rule of 12. And then family dynamics may influence behavior as well. So for adults, partners or for family members that act as the guardian, they can offer similar collateral input. So parents also help identify functional impairment like struggles with homework or chores, and can flag comorbidities like the anxiety and the sleep issues that we talked about earlier. So engage with parents with tools like the Vanderbilt or the Conners, right? Those parent scales, and then ask open-ended questions like, how does your child's behavior compare to their peers? Then for teachers, they observe children in a structured setting where ADHD symptoms like inattention or impulsivity are often most apparent. So they can compare a child's behaviors to classmates and then provide a developmental benchmark. So for example, a teacher, they might note that a student can't stay seated during lessons or are frequently interrupting, and that aligns with the hyperactivity-impulsivity stage or situation of ADHD. So teacher versions of the Vanderbilt, the Conners, and the ADHD-RS-5, these are critical for really capturing those school-based symptoms. So for the exam, know that discrepancies between parent and teacher reports don't rule out ADHD. Different settings may highlight different symptoms. So why does collaboration matter here? Well, patients and teachers provide this ecological validity, okay? This is going to ensure that symptoms aren't context specific. For example, due to like stressfulness or a chaotic home environment or just this challenging classroom. Maybe they have a hard time with the specific teacher or they're just being bullied. Not just being bullied, but it's this situational context that doesn't tie it into ADHD in general, okay? So their input is really going to help you differentiate ADHD from other lookalikes that could be out there. For example, even trauma. So a teacher might note academic struggles that are specific to reading, pinpointing a learning disorder, while a parent might describe pervasive inattention that would then support ADHD. So separately, they look different, but when viewed together, we have this painted picture of ADHD. So involving both are going to really build trust in the process of diagnosing between you and the parent, and then it's going to help that ensure proper interventions are put into place, like behavioral strategies or 504 plans that are feasible across the settings that are necessary. Now, for the exam, I want you to expect scenarios where you interpret parent and teacher reports to confirm ADHD or to identify any red flags for differential diagnoses. Now, here's your pro PMHNP tip here. If a parent and teacher rating conflicts, dig deeper with a clinical interview or additional collateral sources like coaches or babysitters. We need to go a little deeper to find out why we have some disparity between the two. All right, so that really sets us up for understanding what comes next when we're dealing with the challenges of diagnosing adult ADHD without childhood diagnosis. So again, before we can get into the actual treatments and interventions, a proper diagnosis has to be put into place. So let's talk about diagnosing ADHD in adults who weren't previously diagnosed in childhood, because it's tricky due to multiple factors, right? Rooted in that the disorder is neurobiology and it's neurodevelopment. Therefore, the presentation and the diagnostic criteria is a little skewed if they come into you as an adult but haven't ever had an issue with it as a child. Or maybe it just wasn't reported because parents didn't believe in mental health, or they didn't have the finances appropriate for seeking care. All right, so DSM-5 requirement, remember, childhood onset, mandates that several ADHD symptoms have to be present before the age of 12. That is hard to verify in adults. So retrospective recall of childhood behaviors is often heavily unreliable, okay? Patients, they just don't remember early symptoms, or they lack any type of collateral resources like parents or, the school records. So an example would be an adult might recall struggling with homework, but doesn't recognize that they were always inattentive, right? And so this reliance on memory complicates the diagnosis, especially if childhood symptoms were mild or they were masked. So atypical symptom presentation in adults, unlike children, adults with ADHD often show less overt hyperactivity, and they really have more subtle inattention or impulsivity. So symptoms like chronic disorganization, time management issues, or impulsive decision making like job hopping or risky spending of money, right? These may be mistaken for personality traits or stress, okay? Women in particular are underdiagnosed because they often present with inattentive symptoms rather than hyperactivity, which is historically tied and studied in boys. So this gender bias contributes to misused childhood diagnoses. Now, comorbidities and differential diagnoses for adults with undiagnosed ADHD, this is often going to develop into co-occurring conditions like anxiety, depression, or substance use disorders, because we're using them as coping mechanisms or consequences of untreated ADHD symptoms. Now, these can obscure ADHD, and that's going to make it really hard to distinguish whether inattention stems from the ADHD, from the depression, or from both, and so on and so forth. So, for instance, a patient with generalized anxiety might appear distracted due to worry, not ADHD. And the differential diagnosis, like a bipolar disorder or a borderline personality disorder, that again is going to further complicate any type of diagnostic picture. So with many adults with undiagnosed ADHD, they develop coping mechanisms like relying on high intelligence or structured environments in order to mask the symptoms in childhood. So these strategies may break down under demands of adulthood, right? As they get more responsibilities in adulthood, in their jobs, as they become parents, or they have, more in-depth and stronger relationships, that's going to reveal ADHD later as that pressure starts to cook up and then could explode into the ADHD symptoms. So an example here, we have a patient who excelled in structured school settings. Now they might struggle in a chaotic workplace, and that's where we need to see good evaluation take place. Now, we do have to remember stigma and a lack of awareness here. So historically, ADHD was viewed as a childhood disorder, and early research focused on boys, all right? So leading to an underdiagnosis in adults, especially women, and in minorities as well. So adults may not seek help due to that stigma or this lack of awareness that ADHD persists into adulthood, delaying the diagnosis until significant impairment occurs. So for the exam, know that these challenges require a thorough history and collateral information to meet DSM-5 criteria, especially the age of onset rule. So misdiagnosis risks are high, so a systematic approach is critical to diagnosing. Now, diagnosing ADHD in adults requires a comprehensive multi-step process that's going to account for challenges that we just talked about. So let's talk about some evidence-based recommendations and techniques that are tailored for PMHNPs. First is going to be that comprehensive clinical review. So we want to start with a detailed history. We want to focus on current symptoms, childhood behaviors, and functional impairment. We want to ask open-ended questions like, did you struggle with focus or organization as a child? Or how do you manage, and then ask them to elaborate, right? And then how do you manage daily tasks now? We want to explore academic, occupational, and social history for patterns of underachievement or some type of impulsivity. Now, for adults, symptoms like forgetfulness, difficulty prioritizing, or emotional dysregulation are going to be key for identifying. Then we use the adult ADHD self-report scale. Another one that you consider is the Winder-Utah scale. These are gold standards for adults. For that ASRS version 1.1, we have 6-item Part A, and then we have an 18-item Part B that maps the DSM-5 symptoms. Okay, the Conners Adult ADHD Rating Scale, that's another robust tool. It's going to assess symptom severity and executive functioning. So we have quick, reliable, and exam-relevant screeners and tools that you need to be aware of moving forward. So since retrospective recall is unreliable in adults, we want to gather input from family, their partners, or friends about any of the patient's childhood history and current behaviors. So if possible, we want to review old school records or their report cards for comments for things like does not pay attention, talks excessively, gets in trouble with others. And an example here would be a parent might recall a child's consistent fidgeting even if it wasn't labeled ADHD. So collateral sources, if they're unavailable, focus on consistent patterns of impairment in the adult life. Then also go ahead and screen for those depression, anxiety, substance uses, and personality disorders with things like the PHQ-9, the GAD-7. DSM-5 requires significant impairment in social, occupational, or academic functioning or areas. So we want to ask about job instability, relationship difficulties, or financial mismanagement. An example would be a patient who's been fired multiple times for missing deadlines at work might show ADHD-related impairment. So we want to quantify this with those tools that we've been talking about. And another one that we're gonna bring up, which is the Weiss Functional Impairment Rating Scale, or the WFIRS. So in complex cases, tests like Behavioral Rating Inventory of Executive Functioning, the adult version, or other cognitive assessments can evaluate working memory, attention, and planning. So think of those cognitive tests that we go over in the seminars and how they can apply in these situations when evaluating ADHD in adults. So these are especially useful when comorbidities cloud that diagnostic journey. Now, I want you to be aware of cultural factors that may influence symptom reporting or access to care. So women and minorities, often underdiagnosed. So we want to probe for subtle signs like internal restlessness or overcompensation. And then use culturally competent language in order to avoid any type of stereotyping. So first and foremost, we want to build rapport to reduce stigma, because adults may feel embarrassed about seeking help, especially for ADHD symptoms. So use psychoeducation to explain ADHD's neurobiological basis, help them understand the science, and then normalize the experience based on that neurobiological basis. An example you could use would be your brain's dopamine system might be working differently, which explains why focus is hard for you. So break down the assessment into multiple sessions if needed, because adults with ADHD, they may struggle with that long interview that we sometimes see in mental health. Telehealth can improve access, so especially for those with scheduling difficulties or work schedules that won't allow them to go into the clinic as often as you would like. All right, so moving on to the foundation of pharmacy and pharmacological treatments, because they really are the cornerstone of ADHD management. These are often combined with behavioral interventions for optimal outcomes for the patient. So you as the PMHNP need to know which medications are FDA approved and how to prioritize them and then how they work. And that is so that we can then balance the benefits versus the risk for the patient. So for the certification exam, you want to expect questions on medication selection, age-specific indications, and side effect management. So let's break down the medication systematically here. First, we want to talk about the FDA recommendations for ADHD medications. The FDA, they've approved a wide range of medications for ADHD, primarily stimulants and non-stimulants. These are all based on robust evidence of efficacy and safety. This has been well studied. These medications are really going to target the neurobiological factors that are associated with ADHD. Remember, we talked about it earlier, that dopamine and norepinephrine dysregulation, and also the prefrontal cortex and the basal ganglia. So the FDA approves medications for specific age groups, and treatment decisions are going to align with those indications that consist of the patient's age, their comorbidities, and their preferences for treatment. So general principles are going to include stimulants. So stimulants are the most effective first-line treatments for ADHD, with response rates of 70 to 80% in children and adults. Then we have non-stimulants that are second and third-line options. These are used when stimulants are ineffective, or they become contraindicated, or they're just not well tolerated. We have age-specific approvals. So most medications are approved for children as young as 6, with some extended to age 3. So for example, certain amphetamines like Adderall. And these medications also translate into the adult population as well. So preschoolers under 6 require cautious, specialist-driven management. They must have constant and regular follow-ups in order to assess for the efficacy, the side effects, and growth, especially in children, right? So we need to work really closely with their primary care team, because we need to identify if there's any growth development issues caused by the stimulant medication. So we need baseline vitals, and essential here, cardiac history, in order to screen for any risks that may be present. So for the exam, we want to know that FDA prioritizes stimulants for their efficacy, but approves non-stimulants for flexibility, especially in patients with substance use disorders or some type of known history or current cardiac concerns. All right, so let's talk about those first-line stimulants. So stimulants, like I said, they're the gold standard due to their rapid onset. They have high efficacy, and they have extensive evidence-based. They're divided into methylphenidate-based and amphetamine-based formulations, and they're available in short-acting, intermittent-acting, and long-acting forms. So let's talk about the methylphenidate-based first, things like Ritalin, Concerta. So these are approved for ages 6 and older, children, adolescents, and adults, for most formulations. Now, there are some that are approved in a different age group, but I want you to specifically remember 6 and older for your methylphenidate-based. Now, methylphenidate, this blocks the reuptake of dopamine and norepinephrine, and that's going to increase their availability in the prefrontal cortex and the striatum, and that's going to enhance the attention and therefore reduce the impulsivity as well. So some examples we have here, short-acting, are going to be Ritalin, 4 to 6 hours, 6 and older. Long-acting is going to be something like Concerta. This is osmotic release, 10 to 12 hours, 6 and older. Some of the adverse reactions and side effects that we see with the methylphenidate-based medications are going to include insomnia, decreased appetite, weight loss, headache, irritability, and increased heart rate and increased blood pressure. We do have some rare but very serious situations like cardiac events, like arrhythmias in predisposed patients, so psychosis, and we can sometimes see a priapism develop. So we want to monitor growth in children and long-term use. We could potentially see this slow growth velocity, so we got to make sure that we're very aware of that. Now, quick note here: Concerta's extended release minimizes abuse potential. Okay. Now, amphetamine-based, this is your Adderall and your Vyvanse. These are approved for ages 3 and older for some. Okay, 6 and older for most. All approved for adults. So the mechanism of action for amphetamine-based, this increases release and blocks reuptake of dopamine and norepinephrine, and that's going to boost attention and executive functioning. So some examples here, we have Adderall extended release, 4 to 6 hours, 3+ years, in different variations of the amphetamine, like dextrodrine, 6+ for Adderall. Long-acting, we have Vyvanse, 10 to 14 hours, 6+ years of age. Adderall extended release for 8 to 12 hours. Some of the adverse reactions and side effects here, very similar to methylphenidate. We have insomnia, we have appetite suppression, weight loss, anxiety, irritability, and cardiovascular effects like tachycardia. So rare risks are going to include sudden cardiac death in patients with pre-existing heart conditions and potential for abuse or dependence due to the euphoric effects of a stimulant. So Vyvanse's pro-drug design is going to help reduce some of those abuse risks. Now, note here, Vyvanse is long-acting and less abusable. So that's going to be a top choice for adolescents and adults. So we want to screen for cardiac history and for substance use before we prescribe. So why are these first-line treatments then? Stimulants have the highest effect sizes, 0.8 to 1.0, for reducing ADHD symptoms across ages. They're preferred unless contraindicated in situations like cardiac issues, substance abuse, or severe side effects. Now for the exam, know that methylphenidate and amphetamines are equally effective, with choice guided by patient response and tolerability and age. Now let's go on to the second line, non-stimulants. So non-stimulants are used when stimulants fail, obviously, or they're not well tolerated, or they're contraindicated for those substance use disorders, things like tics, as well as cardiovascular issues. So these are less effective, but have lower abuse potential and fewer cardiac risk. First we're going to talk about is Strattera or atomoxetine. This is for age 6 and older in both children, adolescents, and adults. The mechanism of action, we have selective norepinephrine reuptake inhibitor, so an NRI. This increases norepinephrine and indirectly dopamine in the prefrontal cortex, and that's going to improve attention, impulse control. So unlike stimulants, it has no effect on the striatal dopamine, reducing abuse potential. Some of the adverse reactions and side effects here, common ones are going to be things like nausea, dry mouth, fatigue, decreased appetite, and sexual dysfunction in adults. Rare, but can be serious, are going to be things like hepatotoxicity, so we want to monitor liver function, suicidal ideation, there is the black box warning, okay, especially in youth, 24 years of age and younger, and cardiovascular effects like increased heart rate. So this takes about 4 to 6 weeks for full effect, unlike stimulants that are going to have just a really rapid onset. So a quick note for atomoxetine, this is ideal for patients with anxiety, with tics, or with substance use history. Requires daily dosing and patience because of that delayed onset of 4 to 6 weeks. For the exam, I want you to remember it's a non-controlled substance. Then we have guanfacine extended release, or what's known as inattentive. This is for age 6 to 17. It's off-label use for adults. Mechanism of action is the alpha-2A adrenergic agonists. So this enhances prefrontal cortex connectivity and improves attention. It improves impulse control and then emotional regulation. So it reduces hyperactivity by modulating norepinephrine. Some of the adverse reactions and side effects we see that are common are going to include sedation, fatigue, hypertension, and headache. Some of the rare ones that we have to consider are bradycardia or rebound hypertension, okay, if stopped abruptly. So we want to taper slowly to avoid any type of withdrawal effects. Quick note here for inattentive, this is often used as monotherapy or adjunctive to stimulants for hyperactivity or emotional dysregulation. So it's non-controlled, and that's what makes it safe for substance use concerns. And we also always want to monitor blood pressure with this drug. Next, we have clonidine, the extended release. So this is approved for 6 to 17. It's off-label use for adults. Mechanism of action here is the alpha-2 adrenergic agonist. That's similar to guanfacine, where we're reducing hyperactivity and improving attention by modulating norepinephrine signaling. Adverse reactions here, side effects, similar to guanfacine. We have sedation, hypotension, fatigue, and dry mouth. All right. Some of the rare are going to be cardiac effects or some type of rebound hypertension. So we have to taper this drug. Quick note on this one, it's useful for hyperactivity, for aggression, or sleep issues with ADHD. So it's often given as an adjunctive with stimulants. Therefore, we want to monitor vitals regularly. So why are these second line? So non-stimulants have a lower effect size, 0.5 to 0.7, but are safer for patients with those stimulant contraindications. Atomoxetine is preferred for this broad spectrum coverage, while guanfacine and inattentive, inattentive and clonidine, these target hyperactivity or adjunctive needs. So for the exam, remember, know their slow onset and non-controlled status. Now, we do have some other third-line medication options, things like Wellbutrin or bupropion. These are approved for other things, but off-label use for ADHD. So Wellbutrin is not FDA approved for ADHD. It's off-label use in adults 18 and older. Mechanism of action with Wellbutrin, we see dopamine and norepinephrine reuptake inhibition, so it's an NDRI, and this enhances attention and motivation. It also can be used as an antidepressant, which is useful if we have comorbid depression in a patient. Adverse reactions with Wellbutrin, we're going to be seeing some insomnia, agitation, dry mouth, and we can also see a headache. Some of the rare ones are going to be seizures, which it's always contraindicated in a seizure disorder, or if the patient has a history of an eating disorder like anorexia or bulimia. All right. We have seen some cases that are rare, but suicidal ideation. So we want to avoid in eating disorders. We want to avoid in serious suicidal situations. And all of this is going to be linked to that decreased seizure threshold as far as the seizures are concerned, and that is going to be one of the biggest risk factors. So a quick note here for Wellbutrin. This is good for adults with ADHD and depression, or if they have smoking cessation needs. So non-controlled, but it's obviously going to be less effective than stimulants. Then we do have tricyclic antidepressants. So, for example, nortriptyline. So this is approved for other instances of depression, but it is not FDA approved for ADHD. It is off-label in adults and adolescents. So what is the mechanism of action for tricyclics? This inhibits norepinephrine and serotonin reuptake, and that's what's going to improve inattention, and it's going to improve mood. It's less specific to ADHD pathways, though. So adverse reaction here, there are a lot, and they can be severe. Things like sedation, dry mouth, constipation, weight gain. We can see cardiac arrhythmias, which is going to require some type of ECG monitoring. We have overdose toxicity and suicidal ideation. So high side effect burden. Quick note, tricyclics are rarely used due to risks and better alternatives. So we want to consider using this in a complex case with depression. But for the exam, you're not going to use a tricyclic because it's not going to be the safest option. All right, so some key considerations across medications. Remember, age-specific dosing. What is their mechanism of action? What are the side effect management profiles? What are the adverse reactions that we have to monitor for? And then patient education. We have to explain the mechanisms, okay? So for example, stimulants boost your brain's focus chemicals. And then we have to set these realistic expectations. For example, with non-stimulants that take weeks before they can notice any change or differences. So we have to discuss lifestyle factors like diet and sleep in order to optimize the treatment. So for the exam, I want you to focus on stimulants as first line, methylphenidate, amphetamines, atomoxetine and alpha-2 agonist as second line. These are going to be off-label options as third line. And then no age approvals, no the common side effects such as insomnia and appetite loss, and then rare risks like cardiac events and suicidality. All right, so this was, a really deep dive into ADHD, what it is, how we look at it, how we differentiate between other disorders, and then how we can treat it based on current evidence-based practices. So when you start looking at ADHD for the exam, these are going to be best applied to clinical situations. So take a moment to think about what would you do in a case when a child or an adolescent or an adult shows up with multiple symptoms that fit within the DSM-5 criteria, and then how would you implement treatment options and management based on the pathophysiology, evidence-based interventions, and then ultimately patient-centered care, okay? So one of the quick side things that I want to talk about before we end is assessing tics, okay? So when a patient on a stimulant develops tics, you as the PMHNP, you need to have a thorough assessment in order to understand the nature, the timing, and the potential causes, okay? So first we need to characterize it, describe it. Are they motor tics, such as facial grimacing, shoulder shrugging? Or are they vocal, like grunting and sniffing? So how frequent and how severe? And do they impair functioning or do they cause distress? So we want to use a standardized tool like the Yale Global Tic Severity Scale to quantify the tic severity and the impairment. And then that's going to be really exam relevant here, as it's going to be the gold standard for the tic assessment. So an example here would be a child with new onset eye blinking 10 times per hour during class may report social embarrassment, indicating functional impact. And the question may then go on to state how it was never there before, but as soon as you gave a stimulant medication, now you're having these either motor, vocal, or both tics. Some of the differentials that we have to consider are going to be obviously Tourette syndrome, chronic tic disorder, or the transient tic disorder. We also need to consider neurological conditions like Huntington's disease and post-viral encephalitis, or this could be caused by other medications, antipsychotics, which would lead to tardive dyskinesias. These are rare, but they are exam relevant for you. So we want to assess stressors, we want to assess anxiety, and we want to assess psychosocial factors that can worsen tics as well. All right, before we can resolve and resume this podcast today, we cannot overlook the importance of psychotherapy in ADHD. So psychotherapy is going to be a critical component of management. It often is used alongside medication to address those core symptoms that we talked about earlier. So as PMHNPs, you're going to need to recommend and coordinate psychotherapeutic interventions. And for your certification exam, you are going to expect questions on evidence-based therapies and their applications. So first, we have behavioral therapy. This includes parent training, strong evidence, especially in children and adolescents. This is going to be things like associated theory, operant conditioning. So this forms that backbone, really looking at shaping behavior by consequences. So ADHD children struggle with self-regulation. So behavioral therapy uses a structured reward and a structured consequence platform to reinforce desired behaviors and then reduce impulsivity. So social learning theory, this also applies because children learn by observing and modeling parents and teachers and their behaviors. Now, behavioral therapy modifies the environment in order to promote this adaptive behavior and reduce ADHD symptoms. So for children, it's often involving parent training to teach caregivers how to reinforce positive behaviors and then manage challenging ones. Teachers may also be involved in order to ensure consistently across the settings. So in adolescence, therapy includes direct work with the individual to build self-management skills. And then we want to focus on the practical, observable challenges rather than insight or emotions. And that's what makes it ideal for ADHD neurodevelopmental nature. So parent training programs, things like the parent-child interaction therapy or Incredible Years, also help reinforce positive reinforcement. And we want to look at preventing ignoring behaviors, minor misbehaviors, and interruptions that can really set back psychotherapy options, but we recognize that these are common within these modalities, and we need to work through them instead of ignoring them and treating them as if they don't matter. All right, one other thing that we consider is timeout. So this is taught as a consequence for severe behaviors like aggression. So parents practice a consistent brief timeout. Remember, this cannot be long. This is 1 minute per year of age in a neutral and safe space. All right, behavioral classroom interventions like daily report cards from teachers are also going to help. For example, a child earns a star for each class where they complete tasks without blurting out, or leading this to an active weekly reward like choosing the classroom game, something of that effect. We also have token economy systems where children earn tokens like stickers or points for behaviors like staying on task, which can then be exchanged for rewards like a toy or an outing. Then we have skill building for adolescents. This helps them learn self-monitoring, things like tracking their own focus over time, and then goal setting, like breaking tasks into chunks. So an example of skill building would be a teen that uses a planner to schedule study sessions. checking off any type of completed tasks that they've had, and then setting up a reward for themselves when they break after like 25 minutes, right? So this is going to help give them motivation. So why does this work? Well, behavioral therapy leverages external structure to compensate for those ADHD-related executive dysfunctions. It teaches skills that become internalized over time. So apparent training is going to empower caregivers. It's going to improve family dynamics. So for the exam here, I want you to know that first line for young children and key adjunct for all ages is going to be that behavioral therapy. We also throw in there cognitive behavioral therapy because this is going to help with thoughts, feelings, and behaviors and how they're interconnected, and maladaptive thoughts and how they harm or lead to these thoughts of "I am a," quote, "failure," close quote. It's going to help target executive functioning. And so the self-regulation model, this also applies in CBT eras where we emphasize that ADHD impairs self-control, which CBT addresses through the skill-building exercises. So some of the things and treatments that we can utilize in CBT are going to be organizational skills training, time management strategies, cognitive restructuring, distraction management, and group CBT. So why does CBT work? Well, it really compensates for ADHD's executive deficits because it teaches practical skills and reframes self-defeating thoughts. It helps improve self-efficacy as well. So it's especially effective for adolescents and adults who can engage cognitively. So for the exam, know that CBT is first line for adult ADHD psychotherapy and adjunct for teens. We also have other areas of things like social skills training, which involve social learning theory, developmental theory, and this is really well applied to group settings where we can practice role playing, we can practice social scripts where, for example, a child practices saying, "Thanks for inviting me," in order to build gratitude and connection, rehearsing with peers in a group. And that's what helps give them better communication skills and better social skills. We have video modeling, which children watch videos of appropriate social behaviors, and then we look for them to imitate those behaviors. We look at friendship skills groups. So these are structured groups that teach skills like cooperation, empathy, and conflict resolution because of games and discussions within the group. Then we have parent-teacher reinforcement, caregiver reinforcement skills at home and at school, and we use praise or reward for applying these learned behaviors. So an example would be a parent rewards a child with a sticker for using a learned phrase like, "Can we share?" during play dates. So why do all of these work? Social skills training addresses ADHD-related social deficits by providing explicit instructions and practice, and that's going to help leverage peer feedback and peer reinforcement. So it's most effective when combined with behavioral therapy. So for the exam, know it's an adjunctive therapy for children and adolescents with social challenges. We also have mindfulness-based interventions, things like associated theory or mindfulness theory, the neuroplasticity model, which is going to suggest that mindfulness strengthens prefrontal cortex function, which is important in ADHD for attention and emotional regulation. So in ADHD, mindfulness targets deficits in self-awareness and impulse control. All right, we can also teach some things like body scan, breath awareness, mindfulness listening, the stop technique. If you've never heard of the stop technique, we teach patients to learn to stop, take a breath, observe, and then proceed. And that helps manage impulsivity. An example would be blurting out in class. A teen pauses, takes a breath, and decides whether to speak, participating this in role play activities as well. All right, family therapy is going to be key for these patients and their families. Associated theory or systems theory, this views the family as an interconnected unit where dysfunction in one member, like the child with ADHD, affects the whole system. So ADHD-related behaviors can strain family dynamics. You're going to see that day in and day out in practice. And family therapy is going to address those patterns to help improve communication and support. Attachment theory, this may also apply as secure parent-child bonds facilitate ADHD management. All right, so psychoeducation, super important. Families are going to learn about ADHD's neurobiology and the strategies like structure, reinforcement, in order to reduce blame in the situations. We don't blame the child for their condition. We help them by building them up and giving them appropriate techniques and skills to utilize, which will then improve the entire family. Communication skills training, we want to teach how to practice active listening, so that we understand clear, calm communication in order to reduce conflict. We want problem-solving exercises where families work together to address related challenges, like morning routines that often get thrown out of whack when a patient has ADHD. So offering this structured meeting within the family is going to help reinforce skills within the home, and then that's going to help the members share concerns and their successes as well. So why does all of this work? Family therapy reduces stress. It improves adherence to ADHD treatments because it aligns family dynamics. It's an adjunct. It's not a standalone therapy. So for the exam, know that it's useful when family conflict is prominent. All right, so let's go ahead and make our summary for exam tips within this non-pharmacological area. Behavioral therapy with parent training, most evidence-based, rooted in operant conditioning, and first line for children age 4 to 12. Exercises include token economies and daily report cards. CBT, going to be highly effective for adolescents and adults age 13 plus, based on cognitive and self-regulation theories with tools like planners and cognitive restructuring. Social skills training. This is going to help children and adolescents age 6 to 18 with social deficits. We're going to use social learning theory and role playing. Mindfulness. This is emerging for adults and adolescents 13 plus, leveraging mindfulness theory with exercises like breathing awareness. Family therapy supports children, adolescents 6 to 18 when family dysfunction is present, and that's going to be grounded in systems theory. So for the exam, prioritize behavioral therapy for kids and CBT for adults. Know their theoretical basis, such as operant conditioning or cognitive theory, and be ready to recommend the specific exercises like token economy. So combine therapies with medication for the best outcome, and then tailor to the age and the comorbidity. All right, and really, in a nutshell, that is your psychotherapy toolkit. Behavioral therapy rewards to CBT's organizational skills. These are all evidence-based approaches to empower patients across multiple ages. For the exam, focus on behavioral therapy and CBT as first line, their theories, and then their practical exercises like those daily report cards and also the thought diaries. All right, we've covered a lot in this ADHD podcast, and we'll continue to bring up high-yield content throughout future podcasts so that we don't just kind of forget these things that we learned in this complete overview of ADHD. All right, so as we end today's discussion, I just want to make sure that we really focus on how to center our treatments for the patient, how we can educate the parents who may be afraid to use stimulants so that way they understand the gold standards that are out there based on national practice guidelines, as well as just the general evidence that supports it, and teaching them to not really rely on Google searches, but to trust you as their therapist and their medication management professional to come up with the best options that are available for their children and their loved ones. So that way they feel they're getting a really well-rounded treatment plan. All right, we'll go ahead and end that here. And keep in mind, we do have practice questions for this section. I will upload that link into the podcast description. And you can also find this on YouTube as well as our Facebook and other social media platforms. As always, it is a pleasure being with you. Hopefully you were able to learn something more about ADHD, how to diagnose it, how to recognize it, the neurobiology behind it, and the best options for treatments moving forward with the gold standards for medication management as well as psychotherapies. As always, we look forward to seeing you in the student portal online for our on-demand courses, or if you can, join us for one of our live PMHNP reviews across the country. Just check the website for dates and availability, and you can always reach out to myself via phone, text message, email or chat on the website to find out more about each one of those options for your PMHNP reviews. As always, keep doing what you're doing. You're doing amazing things, not only for yourself, but for all of the populations that you're going to be assisting and helping for years and years to come. Nurse practitioners are vital to the sustainability and the functioning nature of mental health and medical care within the United States. We are the foundation and the fundamental aspects that keep it rolling. So remember that you are important in all of this, and to keep fighting for our ability to practice to our education level as we strive for full practice authority across the United States. Thanks again. This is Dr. John Rossi for Clarity Education Systems and www.pmhnptesting.com. Bye-bye.